Good morning, everyone. I would like to welcome everyone attending this patient safety training. So we're gonna have an objectives for this training that the first one, it will be to demonstrate the concept of harm to patients within healthcare system and to discuss the elements of a culture of safety and to explain the effect of team's dynamic and individual behaviors on safety care, and to describe the significance of human factor in system design. And the final one will be to illustrate the aftermath of adverse event. Me and my team will be presenting the whole workshop, so you are welcome to ask at any time after the end of each session. But before we start, I would like to introduce myself, Makia Majashim from Saudi Patient Safety Center. And as well, could you just introduce yourself in the chat, your name, your title, and the hospital, and country, if you will allow us. And can you just share us what made you smile today or this week? Everyone in this room, could you just okay, we were having this exercise just to know from everyone from. I would like to welcome everyone to share their experience, their countries, their knowledge about patient safety, so we can just share and learn a lot of lessons during this course. So we will give you time in the chat, as well as we will move to our learning objective for the first session. We will explain the concept of harm to patients within healthcare system, and we will explain why blaming and punishing individuals for error rarely improves patient safety, and describe the elements of culture of safety, as well as explain the patients and families, how they can contribute to the culture of safety. And we'll identify the errors that are contributing to the organization's learning system. We will start with this video. I'm expecting everyone will see the subtitles because it's in Arabic. جميع حلول آخر يوم في شهر العسل. لم يقترفوا أي ذنب سوى أنهم شعروا بالألم. لا نعرف من المخطئ ومن الضحية، ولكننا فقط نتساءل ما هو السبب. نعم، رضينا بقضاء الله وقدره، ولكن كيف يمكننا أن نتفادى مثل هذه الأخطاء؟ في هذه الحلقات نحاول أن ننثر أمل ونمسح دمعة لنواعد فجرا جديدا بألسنتهم. كان عام 2010. تضرب في رأس بناتي، ما استطعت أحضر الفرح، وهذا أول فرح ما زوجها حست بألم، اشتكت، فسروا الجميع إنه أنت يمكن متضايقة من الحياة الجديدة أو خايفة متوترة من الحياة اللي أنت مقبلة عليها. أخذت ابتسام إلى المستشفى. كان في الطبيب يعني متخوف إنه ياخذ خطوة، لكنه هو أعطاها الشك في إن عندها مشكلة في القلب.
رجعت البيت مرة تعبانة، اشتكت، مو معقول، أخذوها إلى المستشفى الحكومي، نفس الأعراض النموذجية لأزمة قلبية. الطبيب شاف الفئة العمرية، البناء الجسماني، الأشياء الظاهرة، أخذ قرار إنه ما عندها مشكلة في القلب. وكان قرار بعد ما أخذ تخطيط صادم، لأنه هو بعد ما رجع بتخطيط القلب والنتائج أكد لها إن ما عندك شيء، وإنه أنت بتدلعي وأنت عاملة عروسة، وخذي هذه الأوراق يعني خليها ذكرى عندك، ما عندك أي مشكلة أنت.
بالنسبة لما حصل في هذه الحالة تدخل تحت ما يعرف بالأخطاء التشخيصية. هنالك نوعين من الأخطاء الطبية، الأخطاء العلاجية والأخطاء التشخيصية. للأسف مع أنه يعني جاءت إلى الطوارئ بأعراض تتماشى مع الذبحة الصدرية أو الجلطة في الشرايين التاجية، لم يتم التعرف عليها.
رجعت البيت ألم، أنا أتألم مرة، ألم شديد. تعوذي من الشيطان يا بنتي، تقرأ عليهم القرآن، بسم الله عليك بسم الله. ماني قادرة أتنفس، أنا ماني قادرة أتنفس. المستشفى، الذهاب للمستشفى حيكون نفس النتيجة، والمرض والأزمة القلبية ما أمهلتها 24 ساعة، كانت في أقل من 18 ساعة متوفية في نفس غرفة الطوارئ في نفس المستشفى، نظراً لأنه هو فقط أهمل إنه يتابع الأعراض الحقيقية اللي أمامه.
من المهم جداً المريض يكون واعي ويعرف أعراض الذبحة الصدرية، يكون مطلع على الأمراض بشكل عام.
So coming to the end of this video, I would like just to know if the chat is enable you that you can chat with us and tell us from this video how you can figure out what is the reasons behind the problem. Anyone could share, please? I think the chat is now enabled, so you can just chat with us and tell us what are the reasons behind what happened to the patient in this video. Thank you. Once a patient was misdiagnosed. Another one say diagnostic error. What else? What's wrong with the patient? The history and the criteria. That's good. So a lot of factors make things went wrong. Exactly, thank you, Hind, that ignoring the symptoms due to the age and a lot of factors that could contribute to what happened to Ibtisam. How can patient contribute to prevent this error? What do you think? Patient is always right until proven otherwise. Thank you. What else? Do you think second opinion or visiting another hospital could solve things at that time? Thank you, Mariam. Not to be judgmental and proper assessment. So this is a story that could happen anywhere, any hospital, any country. And I think due to what's happening in our healthcare system, so this story is not the only one, and errors it's happen everywhere, and data is distributed to show that we can't prevent errors. Definitely, all cases are not will be ending as what happened to Ibtisam. Yet, study shows that 1 in 10 patients experience adverse event during hospitalization. So no one, as you know, no one from us coming to the healthcare with any intention to do harm. Yet, patients are harmed every day and they have a lot of consequence, regardless how hard worker are we, how well trained are we, and no matter how good policy and procedure we are making. So errors are still happening. Not only this, roughly 1 in 2 surgeries has a medication error or an adverse event drug. More than 7,000 outpatients are treated in emergency department every day for an adverse event caused by a medication. More than 10 million patients each year experience a diagnostic error in outpatients. So all these data shows that errors are a fact. And 1/3 of Medicare beneficiaries is skilled nursing facilities experience an adverse event. In fact, as a patient safety field has evolved, it's moved away from term medical error, which tends to overemphasize the role of individuals in causing harm. And we have to change the mindset and exploring the real root causes of harm. Means we are not looking for beyond individuals providers. It means taking a close look at the system in which they work, and in reality, actually, patients and their families, they are not the only people sacrificed or they are the victim of harm. Healthcare providers are also suffering. Unfortunately, we in healthcare sector, we are still pointing out and pointing fingers to the healthcare providers. When we just think about the history of patient safety and the patient safety movement, which started since 1999, since the Institute of Medicine released landmark report to Error is a Human, which revealed that between 44,000 and 98,000 died each year in United States hospital due to medical errors and adverse event. Then the following year, across the quality of chasm, 6 aims for changing the healthcare system at the ideal healthcare outlined by reports 6 aims of improvement that we have to begin with. Healthcare must be safe, effective, patient-centered, efficient, and equitable and timely. Then in 2002, the concept of never events across from National Quality Forum. The following year, 2003, the concept of the workload and 80-hour work weeks is highlighted. In 2004, there was a campaign of Lives campaign engaging more than 3,000 United hospitals. Still, the efforts were continuing until the 2007, when the father of patient safety, as we always said, National Patient Safety Foundation, delivered by Lotion Leib, and he began publishing with papers the checklist in ICU. In 2010, the highlight was about the medical errors. In the 2005, we have the Medicare payment, and they focus on value-based rather on volume. So with all these efforts, why do you think we are still having so many adverse events? What do you think, you as a participant, why do you think that we still have medical errors? Policy are there, accreditation is still there. Wait, what do you think? Any participation, please? Any volunteers? Why do you think? Blame culture, thank you. What else? Deviation and variation and compliance. Totally agree. Thank you. What else? System errors. Why there are still system errors? We fail to follow the result. Thank you, Mariam. How about technology? Do you think it's really solving what we are facing every day? Human factors. What else? Lack of communication among care team. Awesome. An amazing, really participation. The stress and overwork. Really, all what you have mentioned is correct. And let's take it one by one. Technology is evolving rapidly. Most of healthcare professionals, physicians, nurses, and pharmacists, we are working together. But during our day-to-day work, how many equipment we have, how many drugs we have, and how many policies we have every day. We have a lot of research findings, we have a lot of data. So we have to deal with these factors every day. And there is not always clear right. Every one of us come from different school, from different college. So what you think right, your colleagues really think is not. So we have such an environment that doesn't help us to think in a good way that we can solve a problem. Also, there is rarely enough time. Unfortunately, we have more than how many 100 patients that you have to see every day and in the clinic, and you have a lot of patients that you have to follow up their results, a lot of things that you have to monitor and control, but you don't have time. So providers are often caring for a great number of patients, but still errors could happen. And patients nowadays are required complex and coordinated care. So patients are expecting us to work in a very organized cycle, and they are expecting a lot of things to be done in a very organized way, but the system doesn't help us. What else? The other factors is the hierarchical nature of healthcare can breed disrespectful and abusive behavior. Unfortunately, this is a fact. Sometimes one of the colleagues in a hospital will underestimate the others, whether they are trainees or they are nurses. So all these things could be a factor. That's why when you will think as a patient safety, so just have a look of a framework for safe and reliable care. A framework for safe, reliable, and effective care. This is be used to realizing the best outcomes for patients and families, which have two broad areas: organizational culture. When we say culture, how is the organizational culture looks like in your organization? So before we start, what do you mean by culture? Any participation? When we say culture, the culture in the organization is mature enough. Underreporting. What else? No teamwork. Those all reflect what? The values, the beliefs, how things are done. Thank you. So when we say organizational culture, which we mean the product of individual and group values, how people are having sharing attitudes, competencies, behaviors, how they work with each other. And the other area, we have to focus about the learning system, which measure the performance and help team to make better improvement. And before we start about talking about culture and learning system, definitely, who's gonna leading this? Are the leaders. Without leaders, you can't, even if you are very passionate about patient safety, you can't progress, you can't move on. So the leaders are a very important role in this framework, and they have to be accessible, they have to listen, they have to influence others, and they have to really role by a role model. When the people and the staff, they can see a good role model who can share the values, and during the day-to-day business, they will really be impacting the other things. What does culture of safety look like? As we say, that leaders should adapt the learning system when they fully engage the work of self-reflection that leads to transparency. Then they have to understand how things are going, the reliability system, science, and the continuous of learning. They have to inspire the others to do a safe act. What they have to do else, they have to create a psychological safety. People in your organization, they have to feel free to speak up and to give suggestions and to share ideas. Not only this, they have to foster the trust. How you can foster the trust in your organization? They will create an environment for non-negotiable respect, ensuring that people feel free and people are valued and they can share opinions without any blame. Ensuring value alignment, that culture is embedded in all the system. So when we say the organizational safety culture, we speak about psychological safety, where we have to create an environment that people are feeling free and comfortable to share their concerns. Accountability, that everyone is accountable for his behaviors and they can share things without being blamed. Negotiation, everyone is really saying their point of view without feeling disrespect, and they are negotiating, taking into consideration that this is a genuine agreement and we are taking into consideration that the safer care is the priority. Teamwork and communication, that should be promoted, the teams that develop share understanding and anticipate needs and problems and apply standards tools for managing communication and conflict. We keep on saying psychological safety. How you can figure out that this environment has a psychological safety? The leaders there or the senior people, they are accessible and they are easily approachable. Not only this, they are seeking to engage all team members. So we don't have a concept of seniority. Even the junior staff, they are feeling very welcomed and very approachable to their seniors. Encourage feedback, and they respond to the suggestions, and they respect and value every team members and his or her input. So this is an environment where encouraging a psychological safety. Let's share our first polls. Hiba, could you share our first poll? We have this scenario, and you can tell us, is this environment encouraging a psychological safety or not? A brain surgeon was about to perform a difficult procedure on a high-risk patient. Several of surgical team members had just met for the first time. The surgeon walked into the room and announced, "Good morning, team. This is a difficult case, and I'm a human like everyone in the room. Please speak up if you see me about to make a mistake or have suggestions to help." She then went around the room and introduced herself to everyone by her first time. Is this surgeon showing a good leadership? Yes or no? We encourage everyone to participate, please. We still have quite numbers they did not share. There's a pulse, I think you can see it in the top of the screen. Thank you. 88% of our participants think that this is a good leadership, and she is encouraging a psychological safety. When we say, and when we talk about accountability, we could just share the SPC definition about just culture. Do you heard about just culture before? The term and the concept of just culture. From the definition, what do we mean by just culture? It's really related to the previous concept that everyone, including the frontline personnel, they are comfortable to disclose errors and including their own, while maintaining professional accountability. So everyone is having a concept of just culture. He should making sure that sharing concerns is welcomed. Not only this, to be accountable about what is happening in the system. What is the benefit of having a good just culture? People know that certain kinds of behavior are not acceptable. So the rules and responsibilities are very clear. People know that they won't be punished for admitting to errors that happen when they are trying to do the right thing. What is the benefit of having a good just culture in your organization? Do you think it's increasing the reporting or decreasing the reporting if you have a good just culture? So moving to the next, why we talk about reporting and errors, we have to know what type of errors, types of human behaviors. We have 3 types: human errors, at-risk behavior, and reckless behavior. So having a human errors, that's showing that there is an intention, doing something other than what should have done. For example, you suddenly notice that while you are driving, you exceed the limit. So things be done without any intention to do. While at-risk behavior, that making an intentional behavior choice, which increase risk. So you know what is the consequences behind increasing this risk, but you still do it. So this is at-risk behavior. The reckless behavior, you continuously disregarding the visible significant risk, and you just disregard whatever happening to you and to others. And this is a complete reckless behavior because you have a negligence. So you promote a culture of safety when you speak up about unsafe acts, knowing the 3 kinds of behaviors. Teamwork of communication, no matter what your role is, we have to work as a team. And this could be when we increase the speak up among the team and when we have a good functioning team, and this will be explained later in the other session. Teamwork and communication, I think everyone know Dr. Lotion Leaf, and there's a story where if you Google it, and you can see that he was really explaining that because he is a senior and he's a physician, and he caused harm to a child, and nobody just highlight the errors because they think that he is a physician and it's improper to tell him that this error is happening. When we move to the other factor is negotiation, giving to the level of complexity. We know that in a teamwork and in every organization, this is the nature of being a teamwork, and it's really nature to have a conflict in any organization, but we have to learn how to negotiate, how to solve a resolution, how to conflict with each others. We finished from the first area, which is culture, and we are going to move to the second area, which is a learning system. But before that, if you see here this circle, there is a culture and learning system. What is in the middle? In this framework, which is encouraging the safe and reliable care, when we talk about culture, and then we will talk about learning system, and on top of that, leaders are really, they are the bush of this culture. So in the middle of this circle, what you can see? Any participating, please? Any participant? What do you have in the middle of this circle? Patient and family engagement. Do you believe that engagement of patient and families could support the patient safety culture? Yes. Patient can identify adverse event, and they can help us and as a system and healthcare providers to inform about adverse event, and they can behave as advocate in their own care. By the way, this is a real pictures from our patient safety caravan, and this is an initiative of patient empowerment that we can engage and encourage patients to speak up, and they have to write the correct questions during their hospitalization. So we do believe that patient can be a good factor of encouraging and promoting patient safety, just as important as encouraging healthcare providers to speak up. It is really important to encourage patients to speak up as well. So the other factors is the learning system, how we can learn from our system. Aside from know that every one of us know that our healthcare system is very complicated. Why change is hard? It's really hard in healthcare system to change, and because the healthcare system is a very complex adaptive system, meaning that system performance and behaviors change over time. So we always have an update. We always have a new things to be adapted. And the other factors that could help us in a learning system, the first thing is improvement and measurement, transparency, continuous learning, and reliability. So we all in patient safety, in quality and patient safety, we have an improvement and measurement process. Some hospitals using Six Sigma and others Lean, and a lot of methodology about improvement projects that could be helping the learning system. In patient safety, and specifically, we are speaking about the RCA and FEMIA and other things. Transparency, that we have to openly share information about patient safety and care with the staff, patient, and families through dashboards, through magazine or newsletter, whatever tools and methodology you have in your organization. The continuous learning, that we could continuously, regularly identifying and learning from defects, and to share and learn other experience from different units and different department. Reliability, that we are always relying on the best practice and promoting the standard of goal failure-free operation over time. As you know, and a lot of you share your ideas about the healthcare system is a very complex system. So sometimes our healthcare workers find a way to move around, or what we call it weak signals, which means, just see with us this example. A nurse pick up a multi-dose vial of insulin instead of heparin, but notice right before Dr. David Bates has studied adverse event in healthcare intensively. He has found that in every case of error that leads to death or injury, there are 10 more errors that have been potential and cause serious harm, but for some reason don't. These errors are weak signals that sometimes is wrong with the system. For example, a nurse injects the wrong medication into the patient, but it is antibiotic that doesn't cause an adverse event. So luckily, there is no harm come to the patient, but with a continuous error, the error could be happening. So using a weak signals will not save the system. That's why when we say why people are trying to sidestep weak signals and they are using, sometimes a lot of them, they say that we have a complicated policy, the policy is too long, we can't read it. So instead of having or forcing people to walk around and having weak signals, let's simplify the policy and have the reliable sources to guide them. Reliability is the ability to successfully produce a product to specification repeatedly in healthcare, that the product is safe, efficient, person-centered care. When you choose not to follow a standard operating procedure, you make system less reliable and put patient at risk. So what do you think of having too many staff having weak signals, or they are working around? They are really trying to not to save the system. They are making things more complicated. So instead of having too many things to make the system more complex, just try to speak up and address to the best practice. When we have, as we mentioned earlier, that people doesn't mean to walk around or to ignore things, but sometimes there are a lot of factors that being busy and having too many patients. So let's have our second poll. The second poll said, on a hectic day at work, imagine you mistakenly hooked up a patient's oxygen supply to compressed room air instead of a forced oxygen. You realize and correct the mistake before any harm comes to the patient. Should you report the error? Okay, we have quite good numbers as a participant, but we encourage everyone to participate, please. So we have 100% of our participants, they really agree that we have to report errors. And thank you for the participant from the chat. They said that we have to report errors because we want it as a lesson learned, and we don't want others to do the same mistake. Moving to transparency, healthcare professionals have a responsibility to speak up about weak signals, and organizations have a responsibility to respond. So without this balance, we can't move on. When healthcare professionals, the organization and leaders, they have to react and respond positively. Why the organization response should be included? This, when we encourage people to speak up and to report, we have to acknowledge them, and we have to thank the individual for reporting and maintaining the communication about what is being done to prevent such an issue in the future. So operational transparency exists when people at all levels can see the activities involved in the learning process, leaders, staff, patients, and their families. So the organization encouraging the reporting, encouraging the speaking up, and encouraging the behaviors. When we say the continuous learning, so the organizations allow to continuously see and solve small problems, which include people doing the work must recognize they have a problem. So before having any continuous learning, we have to admit that there's a problem. Someone must be responsible for solving problems. So responsible and job description should be clear. Who will be advocating for learning and continuous learning? People doing the work must be able to notify the responsible person in a timely way. The responsible person must show up without unfair blame and with a desire to solve the problem collaboratively. There must be enough time and resources to solve the problem. Feedback loops must be provide data back into the various reporting system to share information and generate insights to promote action and learning. So from the first session, we have a take-home message that patient safety is everyone's responsibility. Do you have any questions from what we have said in the first session? Okay, I'm gonna move to the second topic, and we can receive all the questions together. The second topic is patient safety events. And in this session, we have an overview of key concepts in field of patient safety, and we will have talk about what is the relationship between error and harm, and how unsafe condition and error can lead to harm. So again, why do you think healthcare is so dangerous? Why do you think healthcare is so dangerous? You have said some things. We deal with human life. Okay, totally agree. What else? As we deal with human life, what we have to deal, it is a complex environment. Thank you. So it's appear it is a complex environment which has a lot of things to be dealing with. We have a lot of technology, as we said before, a lot of equipment, a lot of cases, and all these things making the system is more complex. And in your country, and everyone in his hospital or her hospital, do you think, are we away from what is happening in the world? As we said in the earlier slide, that we have a huge data of how many patients died every year. Do you think in your place or in your organization, are you aware of what is happening in the world? Definitely no. We lost our beloved family member, patient, and their family, they lost the trust. So these are a lot of examples of what is happening in our kingdom. So errors are happening everywhere. Most of our patients came to us for a tertiary procedure, and indeed all died from a medical error, and we failed them. This was one of the deepest, darkest times in our industry at healthcare sector. We already having several years of production system work, and you can only imagine that this doesn't support the patient. So globally, we are in the same boat, and we are all the victims of what is happening in the healthcare. So what is highlighting in the newspaper is only the tip of the iceberg. That's why we keep on saying, if the leaders did not adapt and did not committed to this, nothing will happen. So most of our big agenda in the world should be started by the leaders. And you can see in this slide, the president of US at that time, it was highlighted in 2002, I think, that we have to reduce a medical mistake, and it should be shared publicity. Not only in US, even in our kingdom, this picture shows that the patient safety is one of our top priority in Kingdom of Saudi Arabia. And this is an example of how leaders create an urgency to have a change. Let's consider the delivery of medicine to be inherent hazards in our industry. When we say ingesting a medication, having a surgery, being placed on bypass, or undergoing dialysis, or receiving radiation, for example. So all come with significant health benefits, but they are not risk-free. In addition to hazards inherent in medicine, accidents analysis has revealed that a human contribution to adverse overcome this. So in order to think differently of what is happening of this complex system, we have to think of this pictures. This is a switch cheese model. It was created by James Reardon. He is a psychology professor and one of the seminal thinkers in the field of human errors. And he called this idea of switch cheese model when he means that the idea of harm is caused by a series of systematic failure in the presence of hazards. So you can see different layers, and each layers have different factors that could cause harm and could cause hazards. These kind of harms divided into latent conditions and active failures. The latent conditions, which means we have a defect in the system and in the design of the organization. Things like poor equipment, designs, or training. But the active failures, things can be seen and felt immediately. Why is things are happening? As we always said, that we have a very complicated system, and this is a top complicated journey that started from organizational top leaders. We have a lot of directive instructions, decisions. Then it could be translated in the line management to a skills, knowledge, and work schedule, as well as technology. A lot of things and attitude patients could be done during this phase until we reach to the point of care. So this will end up sometimes as a human up for failures. The switches model, again, if you think about in different scenarios, this is a very common when we have a COVID time. So when you think that a system could be failing the result and could be failing the heart. So this is a very pure examples and very simple examples of how switches model could be applied to physical distance, stay at home, and how we can avoid harm. Another examples that in the switches model, the time out before beginning a procedure to double check safety. And the other layers, there is an instructions for nurses to speak up if they seek a physician skip a step. The other layer, the physician check physical checklist for providers to follow to ensure that they don't forget a step. The other layers mandate that the 2 or more people that participate in the instruction. So different layers could participate in preventing harms. So again, if we just repeat the first questions, what do you think? And when people make mistakes, what do you think of blaming and punishment? We usually punish or blame individuals instead of the system, but the switches model shows that we could have a good communication if we think about the layers of the system, if we think about how we can reduce errors, including and considering the switches model to think about the system, policy and procedures, and a lot of factors that could help us prevent errors. So it's a bad system, not bad people. To prevent harm, we must study and apply the science of improvement. How? Think about the Unsafe Act. We think the relationship between harm and error like this. So all healthcare encounters of a lot of things and terms. So all errors could be preventable adverse event or non-preventable adverse event. All errors could be near miss, and inside all harm, we have a preventable adverse event and non-preventable adverse event. The preventable adverse event could go to negligent adverse event. Sometimes error will occur without causing any harm, and sometimes error will occur with no one can point it an error, which does not diminish the harm the patient experience. As we take a closer look at the error and harm individually in the two columns, exploring the different scenarios represent the diagram here. So coming to a conclusion that we saw a lot of examples showing that errors are common, causes of error are relatively well known, system failures are the root of most errors. For example, if we just have like what we have a bundles of healthcare system had a recommendation for proper handling a central lines. Bundles are there, policy are there, but do you think there are people who had a design of an effective system? Do you think that is it implemented very well? Can we ensure providers follow every recommendation step every day? So if we have a good system that designed to monitor and control these things, we could have saved the organization. And we are now moving to defining the harm. So if we have a definition of harm, it is anything bad that happens to patient in the course of their treatment. But IHI defining harm for the purpose of measuring it. So harm is unintended physical injury resulting from or contributed to by a medical care that requires additional monitoring, treatment, or hospitalization, or that result in death. Coming to what are the criteria when we say that medical care, but not the absence of care. So the medical care causes the harm, and the harm leads to additional care, for example, more time in the hospital. So patient might spend additional days in the hospital because of harm happened during his hospitalization. The harm is physical, not psychological. And according to this criteria of harm by IHI, we will have a following examples how we can figure out the definition or the criteria of harm. So defining the harm, we said it should be during the hospitalization. Usually we have the few examples of types of injury that could be considered harm, especially from the patient perspective. So this is a general definition of harm, not IHI definition. The error of omission, most definition of harm have focused on error of commission, something that healthcare providers did that result in harm. For example, patient suffered of stroke after receiving too much anticoagulants, but what the stroke was after the providers failed to do something such as a follow-up with important test result. Psychological harm, when you diagnose a patient of cancer, or when you violated his privacy, you didn't actually, you as healthcare providers harm the patient, but he got a psychological harm. And the financial harm, which we mean that when the patient cannot pay the fees for his treatment, you as healthcare providers or as organization, you did not harm, but this is a financial harm go to the patient. And now we will move to the following polls. A surgeon mistakenly operates on the wrong foot, and the patient has to undergo a second surgery. Would the IHI global trigger tool recognize the cause as harm? We will launch now the poll. Your participation is highly appreciated. Why do you think IHI trigger tool recognize this as harm? Do you think it is harm or no harm? Okay, half of the participants are engaging actively. Okay, we can share the result now. 97 of our participants think that in this scenario is, according to IHI, global trigger tool is recognized as harm because the patient has to undergo to another surgery. Yes. Another example, another polls, a nurse administers, sorry. Let's have this. A nurse administers too much of sedative because he misinterprets an order, but the patient doesn't feel different. Would the IHI global trigger tool recognize the case as harm? Okay, this is a tricky question, by the way. That's why we have different answers. And the key answer is included in the scenario up. Okay, we have different participants thinking that it's harm. Okay, the result shows that 76, they think it's harm, but while 24 think it's no harm. The key answer that the patient doesn't feel difference. So according to IHI trigger tool, if doesn't require extra hospital days or hospitalization or extra process, and it is not physically injured, it doesn't consider it as harm. The following poll, a doctor tells the patient that she is HIV positive because of a false lab result, but corrects the mistake before there is any impact to her care. With the IHI global trigger tool, recognize the cause as harm. Now, you know the tricks. That's interesting. We have different answers. So Fahmi is participating from the chat saying different point of view. That's cool. 71 of our participants think no harm because it is, it could be psychological harm, but it is not physical harm. Thank you for your participation. So to improve our healthcare system from the perspective of patients and families, you can see how we can have to expand our definition of harm. As IHI patient safety expert, you could say today's we have unpreventable events are only an innovative way from being preventable. So we have a lot of efforts, we have a lot of things to do to prevent errors, and it couldn't be without collaborative ways and work, and it couldn't be without believing on this. To appreciate just how quickly the preventable harm change, consider the following examples. Before, when chemotherapy for a cancer first emerged in early 80s, the idea was if a little was good, then more is better. So it's no more, it doesn't work this way. There are a lot of things have been changed. So today the oncologists know that low doses of chemotherapy are often just as effective as high doses, require less medical care to manage side effects and cause less harm to the patients. So this is only one example of how we are thinking differently and how we are changing rapidly. In these pictures, we really include patient in every levels of the system, believing that patient engagement in healthcare has been considered as a blockbuster of drug of the century. So what we think of preventing errors, we have always to think about including patient, because most of harm today in healthcare system, they are considering all the factors of the system, including the patients. So most of harm in today's healthcare system is caused by unsafe acts of frontliners providers, but the large system issues. We have a large system issues to rethink about it, and latent unsafe conditions too. We have a different layers to things that could be causing a hazards, and harm can occur when there is no clear identifiable errors, but doesn't change the impact to the patient. So we have to think of the preventable harm changes on specific knowledge and healthcare system. Again, changing the mindset could solve a lot of things. And the take-home message, when you think of patient safety, remember that it is bad system, not bad people, and all of us can improve it. Now I'm coming to the last slide. Thank you so much for your patience and your active participation, actually. And if you have any questions, I'm here. Do you have any questions? Before we take a break for 10 minutes and move to the next session. Thank you, everyone. And let's have a break for 10 minutes. And we'll be back.
Okay. Assalamu alaikum. Good morning, good afternoon, good evening, based on your time. My name is Faisal Al-Ataibi. I'm patient safety specialist at the Saudi Patient Safety Center. Thank you for attending this session. The third session in this training course is about human factor and system thinking. And before we start speaking about the learning objectives, from what has been discussed from my colleague, Ms. Makia, we should reach to some agreement before we start to talk about human factor or system thinking. We agree that our nature as a human being is to make mistake and error. Regardless your job, regardless about being working in the healthcare, you might miss the turn. Even if you are following the GPS, you are missing the important appointment or meeting if you didn't add it to the calendar. So to error as a human, our human nature is to make mistake and error. However, if you are working in the healthcare as a healthcare provider, your mistake and error might cost the patient life, might cause a permanent or a temporary harm to the patient, which is not acceptable. So how can we accept the human nature to make mistake and error while we don't accept the patient's harm? So in this session, we will speak about human factor and system thinking. So what we can do better in our system and considering all the factors that affecting the human performance and actions to influence on the healthcare provider performance and try to improve the patient safety and avoid patient harm. In this session, we have a learning objective to recognize the significance of human factor in the system design, also to identify the role and effect of a human in a complex system. In healthcare, we have a complex system. So how the human can be affected by all the factors that we have, to describe the error reducing principle. There is some error reducing principle that might affect the system design and improve the patient safety, to explain the benefit of the application of the human factor science and how it can improve the patient safety. Also to discuss the benefit and the limitation of the technology. Technology has been an essential part in the healthcare system, and we get advantage and it's improved the patient safety. However, there is some limitation with it, so we will elaborate more in the coming slides. Let's start with a scenario. Let's say that we have a patient who attend to the emergency department. An emergency resident diagnosed him. He found that he's developed an infection symptoms. While the resident is diagnosing the patient, there is another intern who's keep annoying the resident with questions. Later, the resident went to the computer to order him an antibiotics. So the resident keep coming back to him, annoying him with other questions regarding to another patient. So the resident forgot, and he was working in a long, busy shift. So he ordered the antibiotic without asking the patient if he has allergy or not. Then the medication has arrived. He gave it to the patient, and then we have an adverse drug reaction because the patient has an allergy. So the physician or the resident forgot to ask the patient about if they have any allergy to any kind of medications, but he forgot that because of some factor that affecting him. Might be the busy shift, they might be busy by the annoying resident or the intern. So there is a different factor affecting this resident. So here we have a question: what factor do you think most likely affected the resident action? Interruption by the resident or the intern, fatigue because he was working for long hours, inadequate training. He might think that asking patient about allergy is nothing essential about it. The design of the equipment because it didn't show any alert. Did you ask the patient if they have allergy or not? Stress because it was a busy shift. Please answer the question. What do you think was the main reason? Okay. Okay, so as you can see from those answers, all of them are correct. From this scenario, we can see that the human actions and the human performance is affected by different factors, either internally as a fatigue and stress, or interruption externally and inadequate training that he should get it from his hospital, or even the design of the equipment. So as a human being, healthcare provider, we are affected by many factors that affect our performance within the healthcare sector. So to speak about the human factor, we should at least speak about the definition of the human factor. Yes, the human factor has been defined by the Chartered Institute of Ergonomics and Human Factor as the application of scientific information concerning human to the design of the objective and system and environment for human use. So we study the human being in order to design a better system, a better object, a better environment for them to perform better and avoid any mistake and harm to the patient. This is the first definition about the human factor. Another definition which gives the same meaning is ergonomics, or a human factor is the scientific discipline concerned with understanding the reaction among human and other elements of the system, and the profession that apply theory, principle, data, method to design in order to optimize the human well-being and performance and the overall system performance. So the shortest definition for the human factor is we try to fit the system to the human or the person, not fitting the person or a human in a bad system. We try to redesign the system or design it from the beginning in order to make it fit for that person to perform and act in a proper way and avoid any patient harm. So how we can use the science of human factor engineering or principles in the patient safety? There is two common way to use this science in the patient safety field. First, when we have a patient safety event, sentinel event, or any other event, that we try to investigate what was the causes that contributed to the patient safety event. And of course, you have to consider the human factor. What kind of factor that contributed to the human action, which result in a patient safety event. So we have to consider all the factors affecting the human performance. Another thing, which is the ultimate goal of the patient safety, is being proactive, and we don't have to wait until we get to patient safety event. We should think proactively, and we try to redesign a system, or even if you purchase a new equipment and you have a new process in place. So before you start implementing this new process, you have to use the human factor engineering principle in order to consider all the factors that affect the human performance in order to avoid and prevent any patient safety event. Why we need to think about the factor, all these factors that affecting the human performance? Because we are working in a very complex system as a healthcare worker. And from the definition or what has been mentioned earlier by Ms. Makia, we talk about system thinking, system design, system approach. What do we mean by system? Let's agree on the definition, then we move to why we have a complex system in healthcare. The word system describes any collection of two parts that interacting with each other to serve some certain purpose. So if you are dealing with a computer, infusion pump, patient monitor, there is two elements of the system is interacting, two parts of the system is interacting. So we have a system here. The difference in healthcare is not only two parts interacting with each other, it's many parts of the system is interacting with each other in order to treat and diagnose the patient. So for example, if the patient came to the ER that we presented earlier in this presentation, the doctor has to do with the patient. He has to speak with him. So two parts as a people, they are dealing with each other. Then he has to deal with the equipment, which is the technology to order the medication. Then, of course, he have done a lab test, another part of the system. So we have too many elements and part of the system interacting with each other. So this is make the healthcare complex system, and you should care about each the element of the system and how it interacts with the other part of the system to avoid any mistake that will lead to the patient safety event and harm for our patient. So what is the key component of the system? As I explained, there is 5 major components of any system. So we are talking with the people, the healthcare provider, the patient. We are speaking about their physical status, their competencies, skills, knowledge, the culture that we have it, cognitive recognition, and also we talk about their language. Sometimes we have a language barrier between the patient and the healthcare provider, or between the healthcare provider, between them. All these affecting the interaction between the people element, from the healthcare provider to healthcare provider, or to from healthcare provider to a patient. So one of the factors affecting the human performance is apart from the people. The second component of the system, which it can be factor if we are considering the human factor engineering, is the tool and the technology that we are using. The patient monitor, the infusion pump, or even the surgical equipment that use it in the surgery. The third component is the task that we are doing it. Are we following the flow chart? Are we following the policy, the procedure that we have in place, or people is just walking around to make it easier to them? So we have to consider, is the people are following the task in the right way, or they just create a new flow chart for the process and the task to be carried out? So this one of the component of the system, you have to consider it either to investigate in any patient safety event, or to proactively redesign the system in order to prevent a patient safety event. Also, the environment is one of the key component of the system. We speak about the temperature, we speak about the noise, we speak about the lighting. So all of these are affecting the healthcare provider and how they treat the patient. So one of the components to be considered and the factor that might affect the patient, the healthcare provider performance, is environmental factor. Last component is organizational factor. Here we are speaking about the standard that we have it in place, the guideline. Do we have policy for this kind of procedure? The credential and privilege that given to the healthcare provider. We talk about the staff ratio. Do we have a safe staff ratio in our area, or we have a shortage that might affect our cognition or our fatigue, stress, which will result in a patient harm? So these factors also should be considered in your redesigning the system to improve patient safety. So here's the question: why healthcare system is a complex system? Again, we have a diversity of task operation to deliver care to the patient. If he came to the ER or emergency department, he has to go to the lab test. Then we have to get medication from the pharmacy. In every area, we have a lot of tasks to do until we provide the care to the patient. So a lot of tasks to be done in different areas. Interaction with individual, again, interaction between the patient and the healthcare provider as a resident or as a consultant, and also between the healthcare provider teams, pharmacist to the physician to the lab technician. All these interaction between the people make the healthcare system are very complex. Vulnerability of the patient. Sometimes they cannot explain what they are feeling. Sometimes they are not following the instruction. Sometimes they cannot give you what they are feeling if you are trying to touch the pain that they are feeling it. So also one of the reasons that make healthcare system is very complex is a variation of the settings and the area. You might have a patient that you need urgently to take him to the OR. So different setting from the emergency department to different setting to the OR system and different environment that we are working in. So we have to design each area for the specific purpose and for the specific task that should be carried out in this area. Again, the lack of regulations, sometimes different regulation from country to country, from different area to different area. Some hospital is trying to follow up some national and international standard, so that make the healthcare system, there is a variation between hospitals and units. Adoption of new technology, and we know that if you are trying to adopt a new technology, you might struggle first until people get used to it. So they have to be trained. They might do mistakes in the first until they get on with this equipment. The diversity of cases and pathway, different patient with comorbidity, you are dealing with them different than the other without any morbidities. So different cases, different pathway that make it, it's not a standardized pathway. You should take it for every patient. That make the healthcare system is very complex. An example of healthcare system that is very complex is the operating room. We have the surgeon, we have the nurse, we have the anesthesia team. There are a huge amount of people. They are dealing with each other to do a single task. Another example is the medication system, from the prescribing until dispensing until administrating the medication. A lot of process it's gone until we provide the care to the patient. Here we have just an example to show you how the bad system, it can influence the human recognition or human cognition and how they behave. So on the left side, we have a remote control. If I ask the attendees to answer, where is the power button in this remote control? Is it the green one, or the orange, or the yellow? Please write it in the chat. Which button is the power button? Is it the green? Is it the orange or the yellow? Is the orange? Written with the power. Okay, so is it orange or yellow or green? The right answer is the green, which is written the power button. So from this example, we can see there is a bad system design. Actually, it's not written here, it might be menu or other words, but it's not written on the yellow or the orange is power button. The power word is written on the green button. That means it's bad system design for this remote control. So from this example, we can see how your opinion or decision has been affected by the bad system design. So if you want to click on the power button, you might click on the yellow or the orange because you think usually the power button, it will be on one of the corners. So this is an example of bad system design. So if you are a new country and you want to refill your fuel in the car, so you are looking for unleaded petrol. Which one of them is unleaded petrol? The right one or the left one? The orange or the blue? Can you write in the chat, please? As you can see, a lot of signs on the orange and the same with the blue. So it's hard to decide which one is yes, it's the blue one. You are correct. Because this is a bad system design. You are only looking for one word that is that make you distinguish between unleaded and leaded petrol, but there is a huge number of signs that make you and affect your decision. So we need a volunteer here. If we can unmute one of the participants, we need someone who can read this sentence for me. Dr. Rakan. Raise hand, please. Yes. Raise hand to participate and read this sentence. So, Mr. Fahmi, can you unmute him, please?
Yes, can I read?
Yes, you go on.
According to the research at the Cambridge University, it doesn't matter in what order the letters in a word are. The only important thing is that the first and the last letter be at the right place. The rest can be total mess, and you can still read it. With its problem, it is because the human mind doesn't read every letter by itself, but the word has a whole.
You are correct. So thank you, Dr. or Mr. Fahmi, for participating in reading this sentence. As you can see, all the words are written in wrong way, but Mr. Fahmi can read them all because he are assured that the first letter is in the right place and the last letter is being written in the right place. So he can read the word. Can you think of this example when you are dealing with look like or sound like medication? You think what is you are looking for, but you are grabbing something totally different. So you might give a patient wrong medication, or even choosing diagnosis or choosing medication by the system, and you think this is the one that you are looking for, and you choose something different and you give it to your patient, which result in a patient harm. So all these kind of factor is affecting you as a healthcare provider in providing the care to patient, and might result a patient harm to the patient. So from the bad system design or your cognition, as this word has been written in this way because you are looking for it, so it will affect your performance and your action, and might result in a patient harm. So the next slide is human cognition. Next, please. Yes. Okay. The type of error associated with two distinct cognitive process. We have a control thinking error and we have automatic thinking error. Let's speak about the automatic thinking error first. They are called skill-based error. They are rapid. You do it unintentionally. So either because of slips or lapses that you are doing this thing by mistake. So error of execution, you do something wrong without mean it. This is an automatic thinking error, example of slips. But if you forgot to do the right thing, that is lapse, error of memory storage. And both are example of automatic thinking error. So you don't use your thinking or the problem solving skills that you have it in place in order to do this kind of action. So unintentionally, you make this error and it results in a patient safety event. The first type that we have it when we are talking about your cognition is the control thinking error, which they are called mistake or error in planning. This is occur when you are trying to solving a problem and make a decision. So you are intentionally want to do something right, but you do it wrong. So why you do it wrong? Either because you are rule-based or knowledge-based. So you don't have the right knowledge, or because of your rule, you don't know how to act in this situation. So you make this error. So this is the type of error in terms of the cognitive process. As explained by Ms. Makia, we will just go quickly. Error divided into mistakes and skill-based error. The skill-based error, it's divided into slip or lapses, and the mistake is divided into rule-based and knowledge-based. Next. Here, just another example on how error can be divided. Let's speak about the internal and external factor that affecting our performance and action in healthcare profession. So we have the external factor that affecting our performance. We have the alarm fatigue. If you are working in the busy area or ICU, you might have alarm on a daily basis. So you usually dismiss this kind of alarm, that because you're having an alarm fatigue because of this kind of equipment. The workload, because you might have shortage on the staff in your area and you have to do a lot of tasks at the same time. You might feel the workload that affecting your performance and action and even your cognition to do the right thing. You might ask to do multitask in the same time, which might make you make a mistake during the profession of healthcare. Automation sometimes is a good an advantage in healthcare system, and sometimes it's affecting the patient safety, the light, the noise, the temperature that you are having in your unit. It's going to be affecting you and your performance and actions. Speaking about the internal factor that you have it and might affect your performance is the sleep deprivation, limited memory capacity, and we always ask healthcare provider to follow checklists, avoid reliance on memory, because their memory capacity is different from healthcare provider to healthcare provider. So one of the internal factor is your memory capacity. And if you have a limited memory capacity, that might affect you to follow the right procedure. You might miss an important steps, which are double checking the right patient or the right application for the patient, and you might make a mistake that result in a patient harm. The third one is stress, hunger, illness, all these affecting you performance and action, and you are providing the care to the patient. Culture and language also another internal factor affecting you how to interact with other elements of the system, speaking from people to the people. If there is a language barrier, that will affect how the system perform as a whole. Also hazardous attitude, we all speak about the culture, how it's affecting, how it's important to distinguish between human behavior. We have the human error, which is like the slip and lapses. We have the risk behavior and we have the reckless behavior. So if you are having a reckless behavior and you are ignoring an important step, which was putting in the procedure to assure you are doing the right thing, then you're having a reckless behavior. So you should there should be a disciplinary action taken toward those staff who has reckless behavior. So we are speaking about human factor and system thinking. We have a couple of models that been designed to help you to analyze the system in order to investigate any patient safety event or to think about redesigning the system. On the left side, we have what's called Onion model, and on the right side, we have System Engineering Initiative for Patient Safety, SEPS model. On the left side, as we can see, in the middle of this model is the people, patient, healthcare provider, how they interact with each other. Then we think about how the people, the healthcare provider, is carrying out the task. So after that, we think about what kind of equipment and tools the healthcare provider are using when they are undertaking this task and follow the procedure. And then thinking about the personal workspace, about the light, the space they have it, the temperature, the noise, are they working in a busy area or a quiet area? So these things in each part or layer of the onion, you have to consider all the factors affecting the healthcare provider, how they are dealing, how they are feeling, the language, their health status, are they eligible and can do the right task that asking from them. The task itself also, it's highly important. Are they following the right procedure that's been written in the policy? Do we have the right equipment? Is the equipment calibrated? It's give the right result or not? The workspace is helping the healthcare provider to perform in the right way. Then we have the second System Engineering Initiative for Patient Safety. Actually, it was built on the Dunabedian model. If you know the Dunabedian model, structure, process, outcome. So instead of saying the structure, he say the work system or what we have in place. And he divided into 5 components: the person or the people, the task, and the equipment, and the environment, and the organization factor. Again, the person, the people, how they interact with each other, how is their situation, the health, the feeling, the knowledge, the skill, they have it, and then how they carry out the tasks, and then the technology and the tools they are using. Then we speak about the environment. Then we are speaking about the organization. We talk about the staff ratio, the standard, the guideline, the support that they are having from the leadership. All these should be analyzed in order to analyze the system as a whole. And then we move to the process. How is the care is being provided in different phases, in the emergency department, then operating room, how system to system is linked together. And then we are asking about the patient outcome. Do we make the health of the patient is better and we give him better health outcome? And then we think about the employee and the organization outcome, speaking about the cost, about the staff feeling, about the staff stress. All these should be considered if you are trying to analyze the system to optimize the performance of the system. Again, here is just putting the 5 essential components with an example. The people, we are speaking about their feeling, about health status, attitude, knowledge, skills, how they communicate with each other. This is the important thing when you try to analyze this component of the system in order to redesign the system and affect those factors that are affecting the human performance in order to improve the patient safety. When we are talking about the tools and equipment that we are using, whether our tools and technology are suited our needs. Again, you have to think about the calibration of the equipment, if they are giving you the right result, which you're going to build your treatment plan based on. Physical work environment. The physical work environment is the amount of the space that we are having, the noise distraction, the lighting level, and the temperature that we have it. It's all going to affect the human action and behavior and care that we provided to the patient. We have, again, the task we perform, how difficult it is, and it's highly important to make and simplify the task, because if you make it complicated, people will walk around and try to breach this procedure in order to do the easier thing to do. So it's highly important when you think about analyzing the procedure. It's not about following the procedure or not. Also try to think to change the flow chart in order to make it easy to the healthcare provider to follow it. If you make it complicated, people might struggle to follow it, or as a human behavior, we have to breach this kind of procedure. When we are speaking about the organizational factor, we are speaking about the guideline, the standard, the legal requirement that we have it in place nationally or internationally, that we are build our system in healthcare based on and we act. So for example, I will give you an example nationally, that we are now starting to update our national standard. And from the standard that we have it in the 3rd edition, we don't have any safe staff ratio. In the coming edition, we're adding a new chapter of standard for the staff safe staff ratio. This is an example of how we change the organizational factor. We add and we try to enforce some kind of standard to assure that we have a safe staff ratio in each department. This is an example of how the accredited body or the national entities trying to make change on the organizational factor in order to improve ultimately the patient safety. So as explained and presented by Ms. Makia, this one of the important model in the field of patient safety is the Swiss cheese model. So if we have a hazard that coming to our patient and might result in a harm, we have different layer of the system. Think about this layer as a people, as a task, as a equipment. If you try to fill these gaps by redesigning the system, make the change, make an improvement in terms of the equipment, you might adopt a new equipment. So you are filling this gap and stopping the hazard to reach to the patient. So we are assuring that the harm will not reach to the patient because we are filling the gap. We're redesigning the system. We improve the system to avoid and prevent the patient harm and improve patient safety. So designing a safe system. By the IHI, they have three things to consider when you're trying to design a safe system. Next, please. Yes, the first is the core of the healthcare is the healthcare provider. You should recruit and train and retrain the best provider, and you should keep them continuously trained about new knowledge and new skills. This is highly important, but is out of the scope of this presentation. Also, Ms. Makia talked about a lot about the culture of the safety. It's highly important, and it shapes our action and the culture that we have in place. It shapes our practice for the patient safety that we have it in our organization. We are going to speak about how you can design or redesign a reliable system in our hospitals. Next, please. So, system design principle to reduce error. This is the reducing error principle that we have it. Here we have error proofing principle is a 10. So we will speak and elaborate in 4 only. The first one is simplification. The second one is standardization. The third one is reduce reliance on the memory. The fourth is using forcing function and constraint. Fifth is improving access to information, taking advantage of habit and pattern, use visual controls, leverage high performance team, deploy redundancy, eliminate environmental factor, make error more visible. Next. So the 4 that we are going to elaborate is simplify, and as I explained earlier, the more you make the process is complicated, the more people will try to walk around of those procedures. So it's highly important to make the process simplified in order to make sure the people are going to follow them. Standardization is one of the error reducing principle. Try to remove variation and confusion and promote predictability and consistency in the workflow in the hospital. For example, if you are using a patient monitor, and we're speaking about one of the components of the health system is the technology, you try to standardize all the equipment that are being used in terms of the infusion pump or patient monitor or other kind of the equipment. It has to be standardized within the hospital. The third principle is reducing reliance on memory. So again, we have to prevent healthcare worker on reliance their memory, and we should enforce more checklists and reminder to them to keep them using the right checklist and follow the right procedure in order not or skipping one of the important steps, which might result in a mistake that will result in a patient harm. So as you can see, for example, we have a surgical checklist, the timeout checklist. We have it. It's essential. If people didn't follow it, we will have a wrong patient, wrong site, wrong procedure. So it's highly important to follow the checklist that you have in place within your hospital, because it will reduce your reliance on the memory. Using a forcing function, and the best example that I can give you, it's outside the healthcare. If you're trying to withdraw some money, you will go to the ATM machine and you will insert your card, you will put your PIN code, you will get the amount of cash. But first, what you will get your card, because if you are getting the money first, a lot of people will forget their card. So the idea from using forcing function is to replace the step of the process. So when they designed the ATM machine and they found people keep forgetting their cards, they replaced just 2 steps of the process. They assure that all the people who withdraw some money is taking their card first, and then they will take the money. In this case, we avoid people to forget their card in the ATM machine. So this is how you can do in your procedure. You try to think creatively in order to avoid such a mistake or improve patient safety. Next. So in brief, we'll speak about one of the components of the system, which is the technology. And we know that technology has transformed the way that we are providing the care. technology has become essential in any hospital, starting from the electronic health record to the barcode medication administration to the clinical decision support system. All these are just an example of how technology can help in providing the care and assuring the patient safety to our patient. However, it's not always that medication, when we add it to our system, that will add advantage and improve patient safety. Sometimes it will add more mistake and will let people do mistake and cause patient harm. So one of the technology solutions that we use it on a daily basis that it's being built to assure patient safety. Next, please. So common type of technology in healthcare is common desktop application. We are using email for reminder or setting a meeting, word process to write our reports, spreadsheet, internet-based program. When we are talking about the medical devices, equipment, we're talking about the CT scan, robotic surgery, monitor devices, infusion pump, bed lifter, pacemaker. All of these are just an example of medical devices become essential in our era. Medical system and software that is becoming more essential and nowadays. Electronic health record is highly important. Event notification system, digital imaging repository, decision support system that we have it with the physician. All this kind of system is a technical solution, is meant to improve the quality of care for our patient. So here just example, electronic health record. Instead of collecting the information of the patient on a paper-based format, we try to change it to electronic health record. When we are checking the history of the patient, medication reconciliation, electronic health record, it's easy to review the collected data rather than the paper-based record. Computerized physician order entry, it's a form of patient management software. It helps physicians to order their medication and it will show them alert and suggestion based on the diagnosis. Also the clinical decision support system based on the diagnosis that the physician entering, it's helping you to conclude about the patient status and how they can treat him in the right way. All these kind of technology is helping the patient safety and improving the patient safety. So radio frequency identification, and you might use it in your hospital. It's becoming essential in our hospital in order to avoid abductions. So if you are tagged or tag the newborn patient, you will assure there is no abduction because you can track their movement for this. And we know abduction is one of the sentinel events that happen in a hospital. Barcode medication administration, which help to assure you are giving the right medication to the right patient with the right dose and right route. All this has been developed to improve the patient safety and improve the quality of care as a whole. This is just an example of how technology has transformed the patient safety to the next level. Again, as I mentioned earlier, not always technology is helping us. Sometimes it will affect the patient safety in the negative way. So there is some limitation with the technology. We speak about the poor design, as I show you in earlier, speaking about the remote control. If we are thinking about defibrillator, if you put the shock button is a very small, people will make mistake and click another button. So we have to assure that we are doing using the right equipment, which has no poor design with it. When we are planning and assisting the new purchased equipment, we shall assure that the design of this equipment is helping us as integrated with our workflow. Poor implementation, if you are choosing two different equipment from two different vendors, it's hard for people to implement it if you are moving them from area to area. So it's about how you implement the technology, how you are adapting the new technology to you. It will make the use of technology limited. Lack of integration in the workflow. Try to choose the right technology that suit your workflow and the procedure that you have it in place. Again, sometimes we have a lack of compliance to the standard because it was built and manufactured in different places without knowing that we have a national standard. So our job in the planning and assessing the new technology is to assure this equipment is complying with our standard. Again, different vendor, different manufacturer, different equipment, even if they are doing the same purpose. So a different standardized between the equipment, and as our job in the hospital is to standardize the equipment that are being used by the healthcare worker. Improper reliance on the technology, again, technology is helping us, but we have to assure and to double check if they, for example, if you are using clinical decision support system, we should not always follow the recommendation that's being given to them. There is some part on the healthcare provider to check if this is the right diagnosis, this is the right treatment suggested by the system or not. So next. So when we are thinking about planning or assisting a new equipment, or you are being a part in the manufacturer or a vendor that is trying to sell the equipment to the hospital, we have to keep the concept user-centered design in our head. So we have to think about who is the user of this equipment, is the healthcare provider, how we make their work is easier and more efficient. So we try to provide them the equipment that make the manual way of doing the work easier. We try to think about the patient safety. We try to put scenario, what if this happened, how the patient will be affected, to assure the patient safety when we are trying to adopt a new technology. So take home messages is put a good person in a bad system and the bad system wins, no contest. So by the end is about the system and how we design the system, because all system elements are being a factor affecting the human performance. It's not about that we having a bad healthcare provider. It's about having a bad system which affecting the human behavior. Thank you very much. If you have any question, please write them in the Q&A section. Thank you very much. Since there is no question, can we move to the next session? Thank you very much. So the next session will be with Dr. Rakan.
Okay, so good morning, everyone. My name is Dr. Rakan Al-Mughir. I'm the head section of the healthcare provider empowerment at the Saudi Patient Safety Center. I'll be glad to present to you the teamwork and communication as part of this lecture or this training course. So first of all, something to change the environment, cheer you up. We'll have an exercise. I would like to request from all of you to have just a piece of paper. I'll be closing the camera. I'll be giving verbal instructions. Questions are not allowed at this exercise. I'll be giving you verbal instructions. You apply it to this piece of paper, and then I will show you the end product. Is the end product similar to your product or not? This will help you understand how difficult communication is. So I'll give you 1 minute to grab a piece of paper, and then we will start. So let's start now. First of all, fold the paper in half. Let's fold the paper in half. Fold the paper in half, okay? Now, next, let's tear off the right upper corner. Let's tear off the right upper corner. Let's tear off the right upper corner. Now, let's fold the paper in half again. Fold the paper in half again. Okay. Tear off the left upper corner. Tear off the left upper corner. Okay, next, let's fold the paper in half again. Fold the paper in half again. Now tear off the right lower corner. Tear off the right lower corner. Tear off the right lower corner. So I'm going to open the screen now, and let's see if the product is similar or not. So is your product similar to this one? You can write it in the chat. So is your product similar to this one? Okay. Okay, excellent. So this exercise just gives you a glimpse of how difficult communication is. If you are not allowed to ask any questions, if you are not allowed to observe or see what the other person is doing, if you are not allowed to ask any questions or any help from other colleagues, this gives you how difficult communication is. So the learning objectives of our session today is that the effect of team dynamics and individual behavior on care safety, how are they going to affect the care of the patient? Well, we're going to discuss the improvement of communication using structured communication. We'll review the interventions that will improve patient safety and reduce risk during times of transition. So as an introduction to this lecture, teamwork and communication are two of the cornerstones in patient safety and safe systems. We have to promote the teamwork and communication and safety culture, and this starts by analyzing the individual behavior of each staff and each patient. The use of communication tools and structured communication tools, this will aid in the communication process, and the end result will promote the patient safety. When we talk about transition times, what are they? How important are they? They are critical points in the communication process and in the care process. We have to learn how to prevent lapses and breakdowns in communication at these times to help achieve safer systems. So first of all, let's define what is a team and what are the types of teams either in the healthcare or outside the healthcare. So Dr. Eduardo Salas, he's a psychologist who spent more than 30 years in studying and experimenting in the team performance and communication. He defined the team as a distinguishable set of two or more people who interact dynamically, interdependently, and adaptively. They have a common goal and valued goal or objective or mission. Each of them have an assigned specific role or function to perform, and they have a limited time of lifespan of membership. There are different examples of teams across different professions. The types of teams that we talked about, we have football teams and other sports teams. We have military units, aviation crews, rapid response teams. These are all types of teams. In the healthcare, we have this beautiful diagram in the team steps course by the AHRQ. It's called the multi-team system. We have at the top of the pyramid the patient. In direct contact to the patient is the core team. We'll define each team in the next slides. Then we have the coordinating team and ancillary and support services. We have the administration at the bottom carrying all the heavy lifting. And we have outside of the pyramid the contingency team. So let's define the core team. Who are the core team? They are the team that are involved in the direct care of the patient. They consist usually of team leader, and team members. Can you give me some examples of the core team? You can write them down in the chat. So you can cheat from the slide. Okay, so we have the emergency department. For example, they have the core team consists of the physician or the team leader, the nurses, the respiratory therapist, and clinical pharmacists. We have, for example, the internal medicine team. They have the consultant, the residents, the nurses, the dietitians, and with them in the round, they perform the core team of the patient. We have the coordinating team. Who are the coordinating team? What is their definition? They are responsible for day-to-day operational management and coordination of function. For example, the head nurse in the unit or in the emergency department. They design the schedule of the staff nurses. We have the charge nurse in the cath lab. It has to make sure that all equipments or the schedule for the cases are there prior to the day of operation. We have the third team, which is called the contingency team. It is drawn from different core teams and responds to emergent or time-limited events. For example, the rapid response team, most of the hospitals have RRT teams. They are called during emergency situations. They are multiple team members drawn from different disciplines. We have the physician, nurse, RT, all of them constitutes the rapid response team. We have the disaster response team also. The next team is the ancillary service. The ancillary services are service delivery team supporting the core team. They provide a direct and task-specific and time-limited service that facilitate the patient care. For example, the radiology. We call them for a patient who's in the ward who needs an urgent, for example, CT brain. They provide this direct and task-specific and time-limited service to support the core team. Another example is the microbiology, when we draw cultures, the pathology, when we get a sample from the patient. The next team we have is the support service. They are also a service delivery team. They support the overall patient care by creating safe and efficient and comfortable environment. What do they provide? They provide indirect and task-specific time-limited service. For example, the housekeeping. They ensure that the area around the patient is clean. The floor is wiped out. No slippery or water in the floor for the patient to fall down. Then we have the administration, which is, as you remember in the pyramid, they are at the bottom and they carry all the heavy lifting. So they are responsible for the 24-hour accountability of the overall function and management of the organization. So let's have our first poll question. An elderly patient admitted to the hospital with a stroke. The team wants to assess his swallowing before introducing any PO medications. For that, they called the swallowing team. So this swallowing team is considered as part of which team? You can answer it in the poll question. So encourage all of the participants to participate. We have almost 55 participants. Okay. We'll give some more time. Okay, so let's analyze the swallowing team at first. They are not part of the core team, so core team is excluded because they were called by the core team. They are called to provide a task-specific service to the patient. They want to assess his swallowing. Is this task direct with the patient or indirectly? So this is a direct service to the patient. So the best answer for this question is that they are ancillary service. Some of you will argue that this might be a contingency team. We want to administer the medication to the patient. It's not a contingency team because this is not an emergent situation, and it is only one profession. They will assist the swallowing for the patient. They are not drawn from different discipline like the contingency team. So swallowing team is considered as an ancillary service. So next we have the fundamentals of teamwork and communication. So first of all, let's talk about the teamwork culture. The data prove that the main underlying precipitator for many serious events is failed communication, either between the patient and the healthcare provider or between the healthcare providers themselves, almost reaching to 80% of the adverse events. Meaning, if the teams do not collaborate, communicate effectively, value one another's input and expertise, the care will not be optimal. So summarizing this, merely wanting to be safe and effective is not enough. If you are going to deliver highly reliable, high quality care, you need to be intentional and systematic about teamwork. Why is it important? Because all kinds of things can go wrong when there is no strong communication plan or teamwork in place. Wrong treatments might be ordered to the patient. It might be even administered. Appropriate treatments are not considered. New information is not adequately responded to. Critical information is lost or forgotten. So what are the outcomes of effective teamwork? We have many outcomes beyond the patient safety. We have organizational benefits, team benefits, benefits to the patients themselves, and benefits to the team members. So for the organization itself, we have reduced hospitalization time and costs, reduced unanticipated admissions, better accessibility for other patients to the care. We have team benefits, improved coordination of care, efficient use of healthcare services, enhanced communication and professional diversity. For the patients themselves, they will have enhanced satisfaction with care, acceptance of treatment, improved healthcare outcomes and quality of care as a whole, and reduced medical errors. For the team members themselves, they will be more satisfied with the job. They will have greater role clarity. They will have enhanced well-being as supported by evidence. So the benefit of teamwork and proper communication extends beyond the patient safety. Let's come to the teams. How can they be formed? How are they formed? How are they developed? The studies showed that teams in many disciplines go through 4 stages of forming and development. We have the forming, storming, norming, and performing stages. The forming, typically characterized by ambiguity, confusion. Team members, they will not have a clear role. They may not have been chosen to work together. They communicate in a guarded way, superficial, impersonal manner. The storming stage, it is the most difficult stage when there may be conflicts between the team members and some rebellion against the tasks assigned. Team members may jockey for positions of power, and there may be frustration and lack of progress in the task. We have then the norming phase, which is the begin to be performing effectively. They start to communicate openly with each other. They establish and the team starts to confront the task at hand. They generally accept the procedures and communication patterns are established. Then we have the last stage, which is the best stage that the team can achieve, the performing stage. The team focuses all of its attention in achieving the goal. The team now is close and supportive, open and trusting, resourceful and effective. So how do we recognize the effective team? The team members in the healthcare system frequently changing. It is accepted for the team members sometimes to be working with each other for the first time. You can recognize the team member by common characteristics described by Mikan and Roger. They have a common goal, a measurable, common purpose, measurable goals. They have effective leadership, effective communication, good cohesion, and mutual respect. There are some other characteristics. Additionally, you can look them up in the literature. So, is it important to have leadership, and what are their role as leaders? So, the team leaders, they form the pillar of any team. The effective leadership structure the team and maintain it. They listen to and support other team members, help in resolving conflicts, and also facilitate and coordinate and coach the team members. They coach them and coordinate their tasks by making themselves approachable with your actions, your words. Show that you are welcoming other people's contribution, willing to stop if any of the team members has any concerns. The team leaders, they will establish clear goals to engage the team members. The people on a team may be tired or distracted. You can support them by saying, like, for example, okay, we are all doing this procedure. Let's talk about it, what it looks like, what we are doing to do it and to ensure it goes well. So leadership importance and role, they will define the goal for the team members, delegate the tasks, making themselves approachable and empower members to speak freely. They coach them, they maintain workflow and continuously assess the progress, resolve conflicts and ask for help when needed. Most importantly, they are decision makers and organizing priorities. Let's have another poll. At what stage we consider the team that conducts an assessment at the end of the year and implements a plan for transitioning roles and recognizing members' contributions? Are they at the forming stage, adjourning stage, norming stage, or performing stage? So I will repeat it again. At what stage we consider the team that conducts an assessment at the end of the year and implements a plan for transitioning roles and recognizing team members' contributions? So most of you have answered performing. So I know this. There is a new choice which is called adjourning. And this is actually the correct answer. I know it was not in the schedule. So this is an add-on stage. They reach the team that have been through all the phases of team development and performance. They reach at the adjourning stage, which is the parting away stage. They usually recognize the team member contributions. They make awards for the most performing team members. They usually will not work together for the next year or for the next phase of the project or the organization. This is usually constitutes a sad moment because it is parting away. So this is the adjourning stage. Moving on to tools and techniques for effective communication. The first and most important tool is respect. Simply respect the other team members. It will achieve the effective communication and teamwork. Simply showing respect to other team members and patients by listening to them with an open mind, learning individual names. These are all examples of respect. The undermining of team members or their suggestions will erode the team dynamic and cohesion and will create an unhealthy environment. The experts have identified 6 categories of disrespectful behavior in the healthcare setting. The disruptful behavior, defined as any behavior that impairs the medical team's ability to achieve intended outcomes. Humiliating and demeaning treatment for nurses, students, and residents. This is usually for the juniors. Passive-aggressive behavior, passive disrespect, dismissive treatment for patients, and systemic disrespect. We mean by that disrespecting the system and the organization or in the country. Then we have the other tool, which is the structured communication. It constitutes multiple tools. We have the briefing and debriefings, SBAR, the repeating back, and Ask Me 3. These are only 4 tools. There are many tools in the literature that can be used. It is of utmost importance that the organization have standard communication technique anyone in the team can use. Structured communication makes interaction with patients and colleagues more effective, and it is proven by the literature. Starting with the briefing and debriefing, when the team members know the goal, it is much easier for them to spot the things that can go wrong. For example, the objectives at the first of the lecture, if I did not mention it to you, and I brought, for example, the ACLS algorithm, would you be able to spot that this is not part of the lecture? You will not be able to, because I did not give you the objectives of this lecture. But when I give it, most of you will pick up that this is not part of the lecture, because it was not mentioned in the objectives. It was not mentioned to us that this is the goal of the lecture. So briefing, it is done before the procedure, intervention, or even before the shift for nurses or the physicians. It usually used to discuss the plan, what are the expected outcome. It is usually led by the team leader or whoever the team leader appoints. It is like a quick check-in. These quick check-ins will put the team on the same page regarding the roles, expected outcomes, the contingency plan, and sharing and discussing safety concerns. Debriefing, on the other hand, it is done after the procedure or after the shift or after the operation. It is a concise exchange that occurs after the event have completed, consists of 3 questions. What did we do well? What did we learn? And what should we do differently next time? Each team member will contribute to these questions, highlight their concerns, highlight what the team member have done correctly to promote a good teamwork. Next tool we have is the SBAR. Some people write it with an I and some people write it without an I. It is a critical communication tool. Most people use it. Standardized tool to help during briefings and debriefing. I stands for introduction, S for situation, B for background, A for assessment, R for recommendation. This tool, when it is used, it provides other team members with the information needed to act quickly and assurance that you are overlooking the situation. It is usually used in emergent or urgent situations. Let's take this example. So Dr. Muhammad, so I'm a nurse in the CCU. I'm calling Dr. Muhammad, who's a physician in the cardiology team. So I'll begin with a concern or an introduction about the patient. Dr. Muhammad, this is Shadia calling you from CCU for the patient Khalid in room 7, who's admitted for unstable angina. The situation. The patient now is complaining of chest tightness, sweating, and is nauseated. His blood pressure has dropped to 92/49 from normal. Then the background of the patient himself. He's known case of diabetes, hypertension, dyslipidemia. Also, he has a history of stroke 2 years ago. The assessment of the nurse. I think Mr. Khalid is having an acute myocardial infarction. The recommendation from the nurse herself. I think you need to come to assess him now while I'm getting an ECG. So this gives the physician the urgency of the situation, gives him the basic information about the situation that is happening to the patient Khalid in the CCU. While he's going to the CCU, he will start thinking about differentials, what he needs to do, what interventions or other services that he can call. Checking back and teaching back. So these tools are used to close the loop. I'm sure that most of you have heard of closing the loop, ensuring that information is transmitted by the sender, is received, understood, and carried out by the receiver. So in these tools, responding to the information that is received by the sender with phrases like okay or is not sufficient. The message must be explicitly restated and acknowledged through 3 steps. Step 1, the sender will state the message in a comprehensive and concise manner. For example, in a ACLS code, I am the team leader and there is a nurse. I will tell her, please give 1 milligram of epinephrine IV push followed by a flush. Then step 2, the receiver, which is the nurse, she will ensure that she received, understood by restating the message that is sent. So by saying 1 milligram of epinephrine IV push followed by a flush, correct? Then the sender will respond to the message, the restated message by saying correct. After the epinephrine is given, she should announce that the epinephrine is given by the exact route, exact dose, and the team leader will ensure that he received the message. So checking back and teaching back is used with patients, different than the teaching back is used with patients, different than checking back. It is also a closed loop communication strategy. The aim is to confirm that the patient understood what instruction is given to him, what disease status is explained to him, or the procedure is explained to him. It is done without putting him on the spot. An example of this is saying, could you explain what you understood so I know if I was clear? This sentence puts the spot on the provider himself without putting it on the patient. This will help relieve the patient and give him the ease to explain what he understood. The last tool which is the Ask Me 3 tool. This is also used for the patients, especially for low health literacy patients. It is a structured communication tool to involve the patients in their own care. This tool constitutes 3 questions. It is done. It is published by the IHI. What is my main problem? What do I need to do? Why is it for me to do this? So if these patients are given, if the patients or family given these questions before they enter to the patient, before they to enter to the doctor, during, for example, the waiting room in the emergency department or in the clinic, given these questions, it will help them be more involved in their own care. Let's move on to the poll question. A surgical team in the OR is conducting conversation while the patient is being prepared by anesthesia. The team leader introduces himself, gives some information about the patient's previous illnesses, diagnose what they are planning to do, possible complications, and what interventions they need to do in such cases. So what communication tool or tools did this team leader use? Debriefing, SBAR, debriefing, checking back. Can we bring up the poll, please? I encourage everyone to participate. We have also 55 participants. So we have different answers, as you see in the poll. Some of you have answered debriefing, some SBAR, some briefing, and checking back. So let's take it and analyze it again. The team leader, he introduced himself. So this is the I. Gives some information about the patient and his previous illnesses. This is the S and B. The diagnosis and what are they planning to do. This is will get the assessment and recommendations. So they are given before the procedure. So he used two tools, which are the SBAR and briefing. The debriefing is done, as we said, after the operation. Checking back is used during the, for example, operation to send the information and ensure it is well received by the receiver. Moving on to the next section of the lecture, which is resolving conflicts. So critical language, I'm sure some of you have heard of these tools, CUS and DESC. These are critical language tools. The critical language is an alarming language indicating that there is concern for safety of patients, workers, or institution. We can use them to deviate the attention from blaming individuals, even if spoken in front of the families or team members. One type of critical language is advocacy inquiry. There is an assertive voicing of concern in the form of I statement. For example, I am concerned, I feel scared, then genuine interest of understanding what the other person's thought process. For example, are we operating on the correct side? So the CUS, as we see, I am concerned, I am uncomfortable, this is a safety concern, or this is a safety issue. Then the other team member who heard these phrases will have a hard stop and check back the situation to see if there is any safety concern. DESC, on the other hand, is used to resolve conflicts with other team members. They will describe the situation. I sense, for example, I sense that you are upset with me about the order I wrote for this patient. This is a junior nurse talking with a senior nurse, or a junior physician talking with a senior physician. Then express how this situation made you feel. When you question me in front of a patient, it makes me feel uncomfortable. So this is also said by the junior staff. Then they suggest alternatives. If you are concerned or have a question about my actions, please take me in private and say it to me. Then they will state the consequences if this happens again. During a private conversation, I would feel less stressed or embarrassed and could supply more information. And if you do it, for example, in front of the patient again, I might do an actual error for the patient. The last rule, which is the last resort rule, which is the two-challenge rule. The first challenge should be in the form of a question. I am worried. It is also in the statement of an I. I am worried that we are operating on the wrong side. Can we check the patient file? The second challenge should be in the form of a statement supporting the first concern. It should be done by the same physician who stated the first concern or another team member. I am really worried that we are operating on the wrong side. I think we must check the patient's file. Then the challenged team member should acknowledge the concern by replying, I see that you are concerned about the site of the operation or the situation itself. Let's stop and check the patient's file. If this doesn't work, which is your last resort, the team member should raise the concern to a higher authority person or the supervisor or the department head to take action in these situations. Even if your concern is not correct, you have a concern, you have to speak up. This concludes the tools that can be used for communication with other team members. Moving on to the transition of care, which is our last objective, and patient safety. Why the transitions are dangerous? We said before, this is when the transitions, this is when the professional responsibility and accountability for some aspects or all aspects of care for the patient or a group of patients is handed over between providers or locations. For example, during shift changes between nurses or physicians, during shifting the patient from the emergency department to the OR or the ward or the ICU. These are called the transitions of care or handovers. The factors that contribute to losing information at these times, providers who are unfamiliar with each other, frequent interruptions, a lot of information and a lot of patients. Studies have linked that 80% of serious events, as we said, are due to miscommunication during the due to these critical times, which are the transitions of care. How do we improve the transitions of care? This is a tool that is provided by the AHRQ during their Team Steps course, which is called I Pass the Baton. The baton which is used during the Olympics, during the race. So I, introduction, P, patient, A, assessment, S, situation, the other S is safety, V does not have any synonyms, the B is background, A, actions, T, timing, O, ownership, next. So these are the questions you see them in the or elements you see them in the schedule. You have to fulfill them all to ensure that you hand it over the patient safely. Medications, on the other hand, constitutes an important category of harm. The harm ranges from mild adverse event to major life-threatening events like anaphylaxis if you did not check the allergies, as the example that mentioned by Mr. Faisal. Medication use in hospital or out of hospital carries risks and opportunities for errors in medication process are numerous. The process is, as we know, prescribing, dispensing, administering, and monitoring. Medication errors mostly have multiple contributing factors. We can group them into 4 factors. Patient factors, for example, pregnancy, taking multiple medications, Alzheimer's disease, and etc. Staff factors, for example, inexperience, interruptions, multitasking. Workplace design, For example, absence of a safety culture in the department itself or in the organization as a whole. Absence of memory aids that can the provider carry them in their ID badge or placed in the department itself. Poor storage of medication. For example, the look-alike and sound-alike medications are grouped together. They should be separated as the recommendation from the WHO. So a solution for this, for not to break down any important information for the medication, is medication reconciliation. It is done universally in many hospitals to ensure that all medications that the patient is taking, prescribed to them, even self-prescribed by the patient, are in the record of the patient. The standardization of these steps during the whole health journey of the patient is crucial. Other ways to improve the medication error during the transition of care is using generic names, choosing the best medication for each individual, being familiar with the medication you prescribe in your area and in your specialty, knowing the high-risk medications in your area, and using memory aids. The last slide is about patients and family. How can we engage them in improving patients and improving communication and teamwork? Patients and families are the only constants in the healthcare process and in the transition of care from one professional to another. They are, especially in the outpatient setting, they should understand the importance of them being involved. We can involve them by using multiple tools, for example, the Teachback and Ask Me3. This will help empower them and achieve a safer healthcare. Some best practices to apply when using these tools and in general are use common and simple words and language to be as clear as possible and minimize the risk of misunderstanding. Speak more slowly when providing instructions. Ask open-ended questions to assess the patient's understanding of written materials such as prescription labels. Also, you can use the written instructions to help achieve a safer healthcare and help achieve that the better patient understanding. This concludes my lecture, and I'm happy to receive any questions in the chat or in the Q&A. So Dr. Prashant is saying a very informative presentation, also Olabisi. Thank you so much for attending. This will not happen without your attendance. Thank you for attendance. So if there are no other questions, we're moving on to Ms. Lamia with her lecture. Thank you. So I think it's better to have a refreshing break for 10 minutes. We'll get back at 1 p.m. sharp. Let's meet then with Ms. Lamia for her lecture.
Hello and welcome everybody. So welcome back. Now we are going to start our last session about adverse events aftermath. Hope you had a great break. So thank you for holding on until the last session. Actually, this is very important to every healthcare provider to understand and to participate and to also give an opinion about. So hope everybody has already joined. Let's just give them 1 extra minute for our participants to rejoin or to come back from their breaks. So is my screen clear for everybody? Just thumbs up if you can see my screen. Okay, great. Okay, so I would like to introduce myself. My name is Lamia Al-Hazani. I work at the Saudi Patient Safety Center as the head of patient empowerment section, and I'll be talking about adverse event aftermath. Okay, so our learning objective here is after completing this course, you will be able to describe the 4 steps to take following an adverse event and explain the open disclosure and when you should apologize to a patient or to a family member, discuss the impact of adverse events on providers, which are called the second victims in some situations. Okay, so let's talk about the 4 main steps after an adverse event has encountered. First, I would like to start with a poll asking you about what is the correct sequence of the 4 main steps after an adverse event has encountered. So I would like to share the poll question. Okay, so the first one is, should we talk to the patient or their family and then attend to the patient's medical needs and then report the adverse event and then document? Or the second one, which is report and then attend to the patient's medical needs, or talk to the patient or family and then document? Or is it the last option, which is first attend to the patient's medical needs, then talk to the patient and family, and then report or document? Let's take a couple of minutes for our audience to answer this poll. So what do you think the correct sequence is? I would like everybody's participation. So either based on your experience or based on your knowledge, what do you think that the best sequence is after an adverse event? Okay, that's great. So as you can see here, most of the answers are toward C, which is attend to the patient's medical needs and then talk to the patient and their family and then report and document. So let's see our presentation. Let's go back to our presentation. Okay, so the first, whoever answered C is correct. So the first step after an adverse event is to attend to the patient's medical needs and then talk to the patient or family members and then report, lastly, document. Why is the first step is to attend to the patient's medical needs? It is the most important thing. So sometimes an adverse event happens with no harm. So you attend to the patient, no medical needs needed. So you talk to the patient or their family and then report and then document. But when the patient is harmed, it is very important to first think about the patient and assess their medical needs. So when something goes wrong, the first priority is to address the current healthcare needs for the patient and assessing their condition and determining what if they need or to be done immediately to the patient. So the second step is to talking to the patient or family. So deciding exactly when and how to communicate with the patient after an adverse event takes good judgment and should be informed by organizational policy. It is helpful to approach these decisions as a team and to assign a leader of the communications effort. So when talking to the patient, it's not just going to the patient's room or going to the clinic and just start communicating with the patient. It needs a lot of organizing and a lot of preparation that we are going to talk about later on in the second part of our presentation. So talking to the patient and family needs a lot of efforts and planning and organizing, but it is important to inform them and engage them after an adverse event. The third step is okay, so talking about talking to the patient and family, is about answering their questions, offer emotional support, or apologizing to them, or showing them that it wasn't meant to be happen, and we regret this happened to you. And do not blame any clinician. Don't point out fingers when talking to them, and do not speculate any outcomes or any that have been gone wrong, or while early speculation. So it is very important to answer the patient questions, emotional support, and not blaming clinicians and not speculate any outcomes. The third one is reporting the event or reporting the sentinel event. When an adverse event occurs, various people, departments, or entities may need to be notified. For example, if it depends on the majority or the harm that happened to the patient. So in some cases, reporting needs to be done to the physician or responsible physician for the patient, if not already involved. And the risk manager or patient safety officer or quality officer also need to be reported or involved. The nurse manager of the ward if it happened in inpatients. The CEO or chief executive, also depending on the situation, the board of directors or the Department of Public Health in some cases. So typically, you should tell your manager directly. If you are a frontliner, for example, you are a nurse or you are a healthcare provider, physician, you need to tell or involve your direct manager and clinical leader about any adverse events, even lesser ones, even the ones that did not cause any harm. Beyond that, you should be aware of the policies at your organization and how to access individuals or departments who can help you if you need it. Second thing, hospitals generally have risk management, quality, and patient safety department to take the lead in the reporting process. If you have questions, your risk manager or quality or patient safety officer is often a good place to start. If you have any different, if, how, and when different people or groups should hear about the event, varies based on the circumstances, such as the severity of the event or the harm that happened to the patient. Although serious adverse event may get the most attention, it is important also to recognize that every failure is an opportunity for learning and improvement and development. This includes the near misses when the patient isn't actually harmed. So talking about reporting or sentinel event reporting, based on the SBAHI, which is our accreditation body, and also similar to that in JCI, all accredited healthcare facilities must report a sentinel event. So this is a must task on all healthcare institutions and all healthcare providers to report a sentinel event. So the last step is documentation. So as applicable, documentation should include the objectives and details of the situation written in neutral, non-judgmental language, the patient's condition immediately prior to the event, the intervention after the adverse event, what did the healthcare team or the healthcare provider did after the adverse event happened, notification of the primary care physician and attending physician, and information shared with the patient and or the patient representative following the event. So everything should be documented and more of beyond that. So now we have a poll here, but before we raise the poll, I would like to read the case study. Yesterday, your colleague was out sick, so your patient load was higher than usual. While making your rounds, you quickly read the chart of patient recovering from a total hip replacement. The patient had been suffering from nausea caused by the morphine prescribed to treat this pain. So you switched him to different pain medication, hydromorphine. Today, the patient nurse explained that the patient became disoriented and combative last night. You realized with horror that in your hurry, you miscalculated the conversion from one narcotic to another and accidentally order a 7-fold overdose of pain medication to an elderly patient. So from this case study, as a caregiver in this situation, what is the very next thing you ought to do? Please raise the poll. So what is the first thing you need to do after this situation, which is realizing that you calculated the medication wrong and you provided the patient with the wrong medication? So what is the first thing you should do? Is it apologizing to the patient, or checking if the patient, checking the patient and if necessary stabilize the patient, or respond to the patient concerns about what might happen next, or share what you know about the adverse event with the team caring for the patient and try to determine the cause? So now you are in a situation, you realize that you had an adverse event with medication or a medication error. What is the first thing you think you should do? Okay, let's share the answers. Okay, so most of you answered check on the patient and if necessary stabilize him, which is the correct answer, because as we said at the beginning, the first step after an adverse event, you need to check if the patient is okay or not, and then stabilize him or ask for help. Another poll regarding or at the same sequence. Your organization has a voluntary reporting system for errors. Which of the following incidents should you report? You are about to administer the wrong medication, but the patient corrects you and is not harmed, or you should report you administer the wrong medication to the patient and it causes harm, it causes him to feel drowsiness but no pain, or you should report both of the incidents above or neither of the incidents above. Choice number 5 is mistaken, so please don't choose it. So we should report both events, or only the one that harmed the patient, or the one only did not harm the patient. I'll give you a couple of minutes to read all the options and choose the best answer. So when it comes to reporting, should we report all cases, or we should report only the ones that did not cause harm, or only the ones that did cause harm, or none of the above? So what do you think? The rest of our attendees, what do you think? Okay, so let's show the answers. Let's share the answers. So most of you said that we need to report both incidents, which is correct, because it's an opportunity for learning when the adverse event did not cause harm. And the ones that caused harm, also there is a very important data can be used to analyze it and find improvement opportunities behind each case. So moving on to our presentation. So let's discuss open disclosure. Now we discussed the 4 steps after an adverse event that happened, or that happen after an adverse happens to a patient. And now we are going to talk about open disclosure. I would like to read some comments from you. What do you understand from the word open disclosure? So when you read it or when you hear open disclosure, what do you understand? Is it a meeting? Is it a form? Is it, what is it exactly? Can you write in the chat box What do you think open disclosure means? Or have you ever heard about it? Telling the truth. Okay. What else? In one word, 2 words, anything. What do you think open disclosure means? Transparency. Explaining to the patient exactly what happened. Truth telling. Okay, great answer. So I think open disclosure as a concept is clear for most of you. And yes, I agree with the keywords that you used to explain open disclosure. So the importance of disclosure. Why is it important? Data from research into patient wishes indicate that most patients want to be informed of adverse events, even minor ones, and major professional codes of conduct emphasize that being open and honest is the right thing to do. So it is important because this is what all patients have the right to hear or to know. And also it is all what they need to know, not to raise complaints or to raise lawsuits and etc. No, because they need to know and to just get it over with. So it's disclosure or having open disclosure with patients will increase the possibility of improvements, not the possibility of complaints. So researchers have long known that stepping up, taking ownership and communicating about events after something goes wrong is not easy. And there are many reasons not communicating with patients about it, and fear of healthcare providers from doing this. So there is a psychological need to preserve a sense of self and fear of admitting responsibility for making an error that may have hurt someone, fear of anger and anger from the patient and someone in authority, fear of loss of job. A lot of people do not do open disclosure because they are afraid to lose their jobs, threat of censure, threat of medical malpractice claims, fear of colleagues' disapproval, fear of negativity or a publicity. They are afraid to be publicly or their image will be used publicly in a bad manner or a bad matter. So the Saudi Patient Safety Center, our organization, recognizes the necessity to address the national need to standardize the disclosure of patient safety events process and emphasize that disclosure is a process of several steps, not a single event. It's not only after an adverse event, meeting with the patient, telling them what happened, and that's it. No, it's several events. When patient safety incident occur, patients need to have timely, full disclosure of the event that include an apology, acknowledgement of responsibility and what happened, expression of sympathy, and discussion of what is being done to prevent the reoccurrence of the event. So when conducting an open disclosure, documentation is a very important step. So the hospital need to document the major points discussed with patients and or their families during open disclosure meetings, including the following details. It goes into details as much as writing the date, time, location of the meeting, the name and role of those present in the meeting, facts presented in the discussion, agreed on care or treatment plan and action, apology provided, what kind of apology provided and from whom to whom, participants' reaction to the responses and the responses to what have been discussed in the meeting, agreed upon next steps, what will happen next, and what we need to do either to assess the patient or to prevent this situation from happening, any plan for providing follow-up and further information to the patient and family if appropriate, and name and details of the patient's contact person. So everything needs to be documented, even the emotions of the family members or the patient in the meeting. So the policy is intended to recommend a national open disclosure framework to encourage healthcare organizations to develop open disclosure policies and a procedure tailored to their needs and resources. So when to disclose? What is the best time to disclose to a patient or their family member? All healthcare organizations need to initiate an open disclosure of all incidents that trigger open disclosure to the patient and or their families as soon as possible and as is practicable. Open disclosure is ideally conducted within 24 to 48 hours after the incident occurs, or become known to the healthcare provider, or as soon as the patient is physically and emotionally available to participate in the discussion, and if deemed necessary to have a support person present. The policy is intended also to recommend a national open disclosure framework to encourage health. Sorry, this is a repeated slide. Disclosure of patient safety policy is also, we built also the time frame or the best events to disclose, if possible, when, and if possible, yes or no. So the type of event, if a harm happened to the patient, should we disclose? Yes, we should always disclose if a harm happened to the patient. If we also suspect harm that happened to the patient, we also should always disclose to patient and family. Okay, now let's go to if there is no harm happened to the patient. Generally, we should disclose. It is important to be sure that harm is not occurred as a result of an incident, and the best way to ensure this is to discuss the incident with the patient. This approach is recommended for most no harm events. If the event is near miss, so no adverse event happened and no harm happened, but there is a near miss, so generally we don't need to have open disclosure with patients because there is no harm and there is no adverse event happen. But it is important to do what? It is important to document. It is important to report. But it is not necessarily, does not need an open disclosure or a disclosure with patients. So there are two main disclosure stages. The first one is the initial disclosure, which is after 24 to 48 hours from the adverse event. The other disclosure meeting needs to be done, or the second stage is post-event analysis disclosure. So the first stage, it is very important to decide who will be involved in the meeting, depending on the nature of the event or the anticipated reaction of the patient. Example, family members, healthcare translator, those required to meet any special needs for the patient. So this is the first thing that stage. The second thing that we need to keep in mind is it is recommended that the most responsible physician should usually take the lead in the meeting, which is the first meeting after the adverse event. In the situation where the main responsible physician is unable to attend the meeting, a suitable delegate can be in charge and clearly explains the reason why the main responsible physician was absent. The third thing that we need to keep in mind, the leader of the meeting should be well trained on how to provide the required information appropriately to the patient and well oriented about the case to provide answers for any clinical questions to the patient that the patient may have. So the initial disclosure process, which is before the investigation and analysis. During the initial meeting, information addressed to the patient or families should focus on the known facts only, with special attentions to the emotional support and information given to the patient are only the facts, no speculation provided. And apologizing is important in this stage. So when we meet with the patient after adverse event that occur, either harm has happened or no harm have happened, it is important to apologize and express sincere and genuine apologies by the healthcare team in each step of the disclosure process. So why apologizing is important? Whether the person experienced a serious injury or was simply inconvenienced, if error or system failure contribute to patient harm, you should apologize. As challenging as it can be, giving a sincere apology can be immeasurably healing to the patient and to you, the caregiver, if it comes to the heart, if it comes from the heart. Okay, now the second stage, the post-analysis disclosure. So the adverse event happened and we analyzed the situation. We did our RCA, we did all the steps needed to study the situation and to find this, and to analyze it. So now we need to do another, the second stage of the disclosure, which is the post-analysis disclosure. An assigned team in the hospital shall review the incident and plan for the next step of disclosure. The team review the incidents may not be the same, may not be the same who plan for the disclosure. So during the post-analysis disclosure, the healthcare facility need to focus on the reason of harm or the reason for harm, apology, and implement corrective actions to avoid the reoccurrence or the reoccurrence of the event. The team shall assess the need of additional meetings or meeting based on the situation and outcome of the first meeting. So it can be only 2 meetings, which is the first stage and the second stage. Sometimes it needs more than 1 meeting in the second stage. So now there is a poll that I would like to raise to our audience. Which of the following statements about apologizing after a medical error is always true? So your institution will perceive it as risky, or your institution will encourage you to do it. Third, you should apologize until you should not apologize until you discuss it with the risk management department, or none of the above is true. So I'll give you a couple of minutes to answer this poll from your point of view. Okay, we need just a couple of answers because I can see a variety of or different opinions in this question. So some of you said that, or most of you said that your institution will encourage you to do it. What do you mean by that? Is there a policy in your institution that says you need to apologize and you need to document that you apologize? So what do you mean by encourage you? Or just encourage you by giving, providing training about apologizing and etc. And those who said your institution will perceive it as risky. Also, this is, I think, based on experience. And some of you said, or one of you said, you should not apologize until you discuss it with the risk management department. And 2 of you said only none of them. So the correct answer from my point of view is none of the above, because there is no right or wrong in, or there is no clear direction to when it comes to apologizing or providing apology to the patient. So it depends on the institution, it depends on the country, it depends on the culture, but there is no right or wrong when it comes to apology. But all we need to know that it is the right thing to do is to apologize to the patient and their family. Going back to our presentation, there is another, I would like to share another poll. When giving an explanation for why an adverse event happened, it can sometimes be a good idea to do what? Give whatever explanation you have at the time, even if some of the information is speculative, or explain how the patient could have helped prevent the error, or say something like there is just no excuse for what happened, or all of the above is correct. So what do you think? Should we explain or provide explanation, whatever explanation, even if some of the information is speculative, or we should explain how the patient could have helped prevent the error. I'm providing the answer to you. So, or say something like, there is just no excuse for what happened. So what do you think? I'll give you extra minute to read the answers and choose the correct answer. I would like to encourage everybody to participate in this question, because I would like to know what would you do, or what would you, what kind of explanation you would provide to the patient after an adverse event from your point of view. Okay, can we share the answers? Okay, so there is differentiation between or similar, there is equality in each answer, so there is no, you did not agree on one answer, but the correct answer is, say something like, there is just no excuse for what happened, because as we said at the beginning of this chapter about open disclosure, it's not correct to provide speculative outcomes to the patient. You should not provide explanation, whatever explanation you have. It's only correct to provide facts to the patient. And the second answer also is incorrect, because you should not explain to the patient, in that situation, how could you help to prevent the error? But it is the right thing to do here is to tell them there is no excuse for what happened, and these are the facts, and etc. So moving on to our presentation, or going back to our presentation. So the last thing that we would like to talk about in this session is the impact of adverse event on caregivers, who we call, or some people call, the second victims. So this is a story about someone called Kim Hayat. I don't know if you ever heard her story or listened to her story. So she worked as a nurse for 24 years when she made her first serious medical error, giving a frail infant 10 times the recommended dosage of medication. The details of Hayat's story, the mistake she made, how she struggled with that tragedy, and how she failed to get the support she needed, were reported by Vox by saying, miscalculated in my head the correct dosage according to the milligram to milliliter. Hayat wrote in the patient record, first medical error, I am simply sick about it. She's not happy that this medical error was done by her. She was escorted from the hospital building and told to stay away and not to call. 4 days after the medication error, the baby died and Hayat was fired. What do you think happened to her? 7 months later, Hayat killed herself. So she was a second victim. She made a medical error. She needed support. She did not do it by intention. She did it by mistake. So the story showed the importance of supporting caregivers like Kim Hayat, whom some refer to as second victims. So defining second victims, they are healthcare providers who are involved in an anticipated adverse event, in a medical error, and or a patient-related injury, and become victimized in the sense that the provider is traumatized by the event. Frequently, these individuals feel personally responsible for the patient outcome. So what do they feel, caregivers, after they commit a medical error or adverse event? After an adverse event, studies and show caregivers involved may be feeling a multiple of emotions. So they feel upset, they feel guilty, they feel self-critical, depressed, and they feel also scared. And it's common for them to suffer from the following effects: loss of job, as what happened to Kim, inability to sleep, loss of self-worth, distance from the professional colleagues, and increased anxiety about future errors. Near misses can also prompt such responses, not only the one that happened, or not the ones only that caused harm to the patient or a serious event to the patient. Also, the near misses can cause this kind of effect. So there are 6 steps process for recovery to the second victim. I will not go into details in these steps, but you can read about it from the Canadian Patient Safety Institute. But the 6 steps are: first, they feel chaos and accident response, intrusive reflections, restoring personal integrity, enduring the inquisition, obtaining emotional first aid, and then moving on. So colleagues, supervisor, and organizational leadership can help provide effective emotional support after an event of patient harm. So there is 2 interventions. So the first one is in the immediate aftermath. What should we do after the adverse event happened immediately to the second victim? First, depending on the circumstances, the caregiver may need to take a break or go home or take some time off just to observe what happened and to lessen the anxiety that they're feeling. Support should begin with the team of people with whom a caregiver works every day and extend to the managers and supervisors. Ideally, supervisors should be trained to spot issues when they arise and talk calmly with practitioners about what happened. For the longer term, so this is the immediate action that needs to be done, which is providing them a break or asking them to go home and let them absorb the event that happened. For the longer term, the magnitude of either the adverse event or the caregiver feelings may warrant counseling, perhaps from senior administrator with enough experience to help, or from trained social worker or mental health professional. So they might need counseling or consultation or emotion or mental support in that situation. So why is it important for an organization to offer help and support at the same time? So offering support decreases the risk of future errors, and also it helps prevent depression or decrease job satisfaction, and it decreases the institutional legal risk following the error. And also the organization is legally obligated to provide emotional or mental support to the second victims. And thank you very much. If you have any questions, please write it in the chat or in the Q&A, and I'll be happy to answer them. Do you have any question about the 4 steps or the second victim or about the open disclosure? Please share it. I'll be happy to answer. You're welcome. Okay, thank you very much. I'll be handing the mic to my colleague, Ms. Makia Majrashi.
Thank you so much, Lamia. On behalf of Saudi Patient Safety Center, we would like to thank you.
I'm sorry, Makia, to interrupt you. I'm sorry, but there's one question. So from Evija, disclosure at stage 2, when patient is at home, what is the best to do just written explanation? So it depends. There is no perfect way to do the stage 2 open disclosure. So it depends. You can do it virtually. You can email it to the patient. It depends on what you agreed on in the first stage. So how would you like to move on after the analysis? Because in the first open disclosure meeting, you decide what to do or what the patient want to do in helping in preventing this from happening again. And also asking the patient if they want to be part of stage 2. Sometimes the patient does not want to be part of it. If they decide that they want to be part of it, it is important to meet with them. If the patient can't meet, you can provide them with the outcomes of the analysis. If not, you can meet with them virtually and explain to them what happened and what the analysis or how the analysis went. Was it and how was the outcomes or the results of the analysis of the adverse event, and etc. So there is no one way of doing it. It depends on the situation. I hope I answered your question. And there is also a question from Oblasi saying, why many don't apologize? Okay, this is a comment, fear of litigation, legislation, I think you mean. Is apologizing necessary? An acceptance of guilt? So apologizing is not only acceptance of guilt. Apologizing is showing to the patient or their family members that the healthcare institution as a whole and you as a healthcare provider did not mean this for happening, and you really feel guilty that it happens and you don't want it to happen now or in the future, and you will do your best to prevent it from happening again. So this is the reflection that we need to show patients when apologizing. It's not only that blaming ourselves or acceptance of guilt. It's many things when apologizing to patients. Litigation. Okay, thank you. Thank you, Makia.
I think, Lamia, there are still
yes, okay.
Heated questions, so you can answer them all.
Maybe, okay. So also another question, how about legal issues? So legal issues, it varies from country to country, from institution to institution, but raising legal issues based on studies, most of patients refrain from raising legal issues when receiving an apology or when being honest too. But preventing legal issues is not going to happen by ignoring the situation or ignoring the open disclosure or not providing the open disclosure to the patient. So here are some comments for everybody to read. Thank you for sharing your comments. Of course, apology will not prevent legal issues, no, but in some studies, it showed that it can prevent by a huge percentage from legal issues to be addressed. But in some cases, it's not enough to apologize, but it is important to apologize not only to prevent legal issues from happening. It's important to apologize to show the patients and their family members that the healthcare institution is not did not intend for this to happen and will do its best to prevent it from happening for someone else. Okay, sure. Thank you. Thank you very much. Ms. Makia?
Yeah, thank you so much, Lamia. I do agree with my attendees and our attendees, and participant, that your topic was really heated with a lot of critical issues to be highlighted and concerning our healthcare sector. Now we are coming to the end of our today training workshop, and I'd like to thank all of you, our colleagues and speakers, with the informative session and knowledge, as well as on behalf of our Saudi Patient Safety Center, we would like to thank you all for your time and your active participation as well. And as a part of Saudi Patient Safety Center, efforts to provide you with timely topics and interesting speakers, we would appreciate if you would fill our evaluation survey, which will be sent to your email later on. Thank you for joining us today, and we will look forward to welcoming you back in our future webinars. Thank you so much and have a good day.